My name is Dr. Amode Olayinka. I'm a consultant obstetrician and gynecologist. I'm presenting a study with the title Endoscopic Tubal Restorative Surgeries for Tubal Factor Infertility in a Low-Resource Tertiary Center, a retrospective review. The slide 2 shows the names of the various authors of this work and their center of practice. Tubal factor is a major contributor to infertility in women, and various options of management are available for it. These include tubal surgeries and assisted reproductive techniques (ART). Historically, tubal surgeries were done as open procedures, but this has gradually evolved into microsurgery with gentle tissue handling, and more recently, laparoscopic tubal surgeries. Considering the high cost of ART, endoscopic tubal surgeries have expanded the possible treatment options of tubal factor infertility, especially in low-resource centers. And we have come to realize that assisted reproductive technique and endoscopic tubal surgery should be considered as complementary rather than competitive procedures. The objective of our work was to determine the prevalence of tubal factor infertility among women who underwent gynecologic endoscopic surgeries in our center over a period of time, their fertility outcome, and to identify factors that may be attributable to successful outcome or otherwise among these women. The study was a retrospective one in which the outcome in 33 women aged 26 to 42 years with bilateral tubal blockage on hysterosalpingography and confirmed on laparoscopy and dye test, who had various forms of endoscopic tubal surgery, which include hysteroscopic tubal cannulation and selective salpingography, salpingolysis, fimbrioplasty, salpingostomy, salpingectomy, and bilateral tubal disconnection between 9th November 2016 and 12th February 2020 in Federal Medical Center, Lokoja, was reviewed. The primary outcome measure was clinical pregnancy, and this includes those who conceived spontaneously and those who had assisted conception after tubal surgeries. The data analysis was descriptive and inferential at 95% confidence interval, and p-value of less than 0.05 was considered significant. During the period of the study, 129 women had endoscopic surgery for infertility, and among them were the 33 women who were studied, giving a prevalence rate of tubal factor infertility among the study population to be 25.6%. Majority of the women studied were within the 30 to 39 age range, with a mean age of 34.5 plus or minus 5.6 years. 64% of them were nulligravid, and in about 70% of them, the duration of infertility was greater than 5 years. No other etiologic factor for infertility was found in 60.6% of the women. About half of them had previous history of abdominal surgery, which includes cesarean section, open mammectomy, ovarian cystectomy, and appendectomy. Bilateral proximal tubal blockage was seen in 42.4% of the patients, while bilateral distal tubal blockage occurred in 36.4% of them. Others had mixed or the mid tubal blockage. When laparoscopy was done, the commonest pathology seen was peritubal adhesion, occurring in 42.4% of these women. After tubal surgery, patency was achieved in 81.5% of these women, with bilateral tubal patency occurring in 51.5% of the women, and others had unilateral patency. All these are reflected in Table 1. Table 2. Table 2 also shows that 36.4% clinical pregnancy rate was achieved. 30.3% of these were spontaneous conception, while 2 of these patients had conception after IVF. One of the patients also had conception spontaneously after the IVF conception. The live birth rate was 18.2%, and miscarriage and intrauterine fetal death occurred in 15.2% of the patients. Figure 1 also shows the distribution of the various tubal procedures that are performed. Some of the patients required additional procedure, which include excision of endometriotic tissue, laparoscopic ovarian drilling, just to mention a few. This procedure done and their frequency is reflected in Figure 2. In comparing the procedure to fertility outcome, Table 3 shows that there was no statistically significant difference in the number of patients who achieved pregnancy after the procedure compared to those who did not, and also no difference in those who had live birth and those who had miscarriage or intrauterine fetal death. Table 4 shows that increasing age and increasing duration of infertility are factors against successful fertility outcome, with p-values of 0.029 and 0.038 respectively. The presence of other etiological factors favor a successful fertility outcome. Thus, as we have seen from this study, the advent of endoscopic tubal surgery have given a role to tubal surgery as complementary, not competitive procedure to ART in the management of tubal factor infertility. The prevalence of tubal factor infertility of 25.6% found in this study is lower than the 35.3% found by Olayinka et al. In UCH in a study done in 1986. Although their sample size was larger than this study, Amode et al. In Gombe also found a much higher prevalence of 67.2%. However, their study population were infertile women attending gynecological clinic. Majority of the tubal pathologies seen on laparoscopy were peritubal, perifembral, and additions and fembral agglutination of 57.6%. This is most likely due to the fact that about half of our patients had previous abdominal surgery, thus further buttressing the importance of gentle tissue handling, prevention of peritoneal soilage, and lavage during surgery. Also, infectious causes of tubal factor infertility have been reported to be common in this environment and may contribute to this finding. Thus, the need for aggressive treatment of sexually transmitted infections and pelvic inflammatory disease in our environment. We also found hydrosalpinx in 1 or 2 tubes in 18.2% of patients, almost similar to the 24.1% found by Toka et al. In AKTH Kano when studying chlamydia trachomatis infection among patients with tubal infertility, making a point for the probable infectious cause of tubal factor infertility. In this study, bilateral or unilateral tubal patency was achieved in 81.8% of patients after surgery, and 39.4% had treatment for other factors occurring concurrently. A combination of these factors may account for the high clinical pregnancy rate of 33.3%, as this may have improved the fertility outcome. And although from the study, tubal patency after the procedure was not statistically significant, regression estimate of factors showed that successful tubal surgery, presence of other etiological factors, show positive significance. Factors recognized against successful fertility outcome include increasing age and increasing duration of infertility. This is not surprising, as most of our patients were within the range of 30 to 39, and fertility is known to decrease as a woman ages. Delay in seeking treatment for infertility may also allow progression and worsening of the pathology leading to the tubal infertility in this patient. Therefore, careful patient selection is necessary in offering any option of treatment. In older patients, fertility potential decreases rapidly with advancing age. Thus, evaluation of tubal status should be expeditious, and treatment in them should be directed towards the highest likelihood of success in the shortest time. This is why some of our patients were referred for IVF after our procedure. Also, patients with poor prognosis hydrosalpinges are better treated with salpingectomy and referral for IVF, as was done in this study. In conclusion, the high rate of success following endoscopic tubal restorative surgeries in this study is encouraging, thus giving it a role in offering succor to patients with tubal infertility in the light of the high cost of ART procedures. From this study, we recommend endoscopic tubal surgery as complementary procedures to ART, and it should be considered as an option of management in carefully selected patients. There is also the need to do all that is possible to reduce adhesion formation from surgeries and infectious causes. Our references are in slide 27 through to 30. Thank you very much for listening, and stay safe.